All over the world, even talk to astronauts in space, ships on the high seas, and flying aircraft thousands of miles away. Unlike phone users, ham radio operators talk absolutely free and provide vital communications during disasters or emergencies. To find out more about ham radio, visit us at arrl.org. And remember, unlike the internet, we crisscross the entire globe wirelessly.
WCAB Sweetwater is 880 AM. The Biz, a service of Salem Media Group and part of the Wall Street Business Network. NASDAQ symbol SALM.
Welcome to the Gray Zone.
Welcome, everyone. This is Michael Santo on the Santo Zone with Dr. Levene, Howard Levene at He is a neurosurgeon who does spinal surgery, right?
That is correct.
And you're going to be telling us all kinds of things, all the way beginning with your training, your experiences, how to get into medical school, and just everything imaginable. You have a lot of different interesting facets to your career and your training. So you went to University of Pennsylvania undergrad.
That's correct, Michael. And thank you for having me on your show.
You're very welcome.
I probably should start with the disclaimer that all the opinions expressed are my own and not of the University of Miami Miller School of Medicine, the Department of Neurosurgery, or any affiliates of the University of Miami, or anything else the attorneys need to hear about.
Okay, these are your opinions alone. Everyone understand the opinions of a highly trained spinal surgeon at that.
Thank you.
And, okay, so you went to Penn undergrad.
I should add, though, I don't just do spinal surgery. I still do brain surgery. I'm part of the trauma neurosurgery team at Ryder as part of my practice here at the university and at Jackson Memorial Hospital.
So Ryder, is that the VA, actually?
No, Ryder's the trauma center.
Oh,
that's
part of Jackson.
That's part of the Jackson Hospital system. That's correct.
Oh, that's interesting. So that's a really fascinating topic in itself, brain surgery. Do you find that stressful?
It's very stressful. It's the sort of thing where you know that if you make a mistake, you could really impact somebody forever. If you make a mistake in choosing not to do surgery when one was needed or doing surgery when one wasn't needed, and you wouldn't even know that without a time machine, you can actually hurt someone. That's why all physicians take the Hippocratic Oath and we swear to do no harm. And we really try, or at least good physicians do, try our very best to do no harm. But we're all human beings, and nobody is perfect.
No part of the brain is extra or superfluous.
Not that we know of.
Well, I mean, I think of, and I think there's a famous anniversary when Reagan also got shot, but fortunately it was okay. But his press secretary, James Brady, took a direct hit into the head, major involvement in the brain. He survived. And I don't know if he's still alive now.
No, I don't think James Brady is still alive.
But he lived for decades, and he had cognitive and speech difficulties afterwards. So that would be like a gunshot wound would be a case I would imagine in the trauma part of the hospital you'd have to deal with.
Oh, sure. As a matter of fact, I trained at Temple University Hospital as part of my residency. I guess we'll step back in a minute to sort of give people the full gamut of all the degrees that ended up behind my name and all the pieces of paper on my wall. But Temple ended here. Unfortunately, you would see people with gunshot wounds to the brain and to the spine and to the spinal cord. And as with many things, and I don't mean to be flip or light about it, but there's almost such a thing as brain real estate. There's some parts which are much more dear than others, where you can have a gunshot wound to the brain, and God forbid, no one should have one, but if you have a gunshot to the brain, there are parts of the brain that, yes, won't impair you as much as others. And there are some parts where if you get the gunshot in just the right spot, well, you're dead.
Like the part that triggers consciousness. Isn't there one particular part that you can't restore consciousness if it gets destroyed?
It's not so simple as that. And, even the brains between men and women are compartmentalized differently. And even the areas that we're used to thinking of as this is a speech area may be a little different on different people's brains. But, for example, there's deep structures in the brain called the thalamus, and plural will be thalami. And if you have a through-and-through gunshot wound that takes out both of the thalami, you're pretty much dead. And I've seen that, and there's nothing anyone can do to save you. And it's really a horrible thing. But it's the things you see when you're taking care of some of the sickest people.
Well, it's interesting. I remember there's a famous historical case, and I think the interpretation of it has shifted, or maybe is overly interpreted. The famous acquired psychopathy case of the guy who was injured in the head.
You mean Phineas Gage, who
Yes.
was the railroad worker?
Yes.
Yeah. Since we're talking about everything, I must tell the audience I didn't memorize these things in advance, but basically,
no, we're just having a conversation. We're very spontaneous
so
here.
what happened with Phineas Gage, if I remember correctly, he was working on a railroad, and there was an unfortunate explosion, and a piece of metal basically got shot through his head, and he survived. And what was very interesting to the neurologists, and I don't think they really were true neurosurgeons at the time, but to the physicians of the time, was the abrupt change in his personality, that he went from being a, shall we say, a more mild or medium-tempered man to suddenly someone who was who would swear and was out of control. And it just showed how much the brain had an effect on personality. It was really a very startling finding for people. But that really was a big factor in people understanding and learning, there are parts of the brain that do affect people and their personalities.
The acquired psychopathy.
Right. And in the old ancient days, before people knew what the different parts of the body did, some of the early anatomists even theorized that the brain was actually meant for heat release, like a giant radiator, because they saw all these blood vessels going up to the brain, and there's nooks and crannies and crenulations, and what your mother told you as a kid, put your hat on, and you're going to catch a cold if you go out in the cold weather. We don't have a lot of that down here. I'm giving away my northern roots, but there is truth to that. You do radiate a lot of heat from your head, but the early anatomists wondered if the brain was just a radiator, and of course we know that's not true.
And you grew up in what part of the country?
I grew up in South Jersey, in a town called Cherry Hill, and
near Princeton, right?
Cherry Hill, south of Princeton. So Cherry Hill, South Jersey, Princeton's about Central Jersey.
Okay.
And I should, for some reason, this reminded me. I don't want to forget to wish a happy birthday to my mom tonight. And so happy birthday,
Howard's mom.
Thank you very much.
Is she listening right now?
I hope so. And
880. What is it? 880thebiz.com.
That's right. And I certainly sent the link to my friends and hope that they are listening too. So hello, friends. And since we're jumping around a little bit, you asked me about what were the various places that I went to and trained to. So started out in Cherry Hill, went to a great public school called Cherry Hill High School West. And by the way, one of our graduates is seriously being considered for the general manager position of the Phillies. So.
Oh, wow.
Yep.
Are you a Phillies fan?
I am a Phillies fan, and I'll admit to that. And so go JJ. Anyway, for undergrad, I was at the University of Pennsylvania, which is in Philadelphia, not to be confused with Penn State, which is in Happy Valley. And I studied.
Is that what it's called, Happy Valley?
Happy Valley is the nickname for where Penn State is. It's truly a joyous place. I've been there. My mother went there. My brother went there. It's really an excellent school in its own right. But I went to Penn. It's one of the Ivy League schools. And
that's the confusing thing about Pennsylvania is you have a private Ivy League school named University of Pennsylvania.
Correct.
And then usually the main state school in a state would be like University of Florida, University of Illinois.
Right.
And usually, Florida State or Illinois State is not like the main school. And yet at Penn, it is the main school in Pennsylvania.
Well, what people call the main school, I guess, would be up to interpretation. But
I mean, in terms of the state schools, usually
Well,
usually
state
it's a little bit easier
Pennsylvania
to get
State School, right?
into the Michigan State is easier to get into, honestly, than University of Michigan.
Well, it's true, and certainly the Ivy League schools are more exclusionary, and they are harder to get into. And I can tell you that from personal experience. But yes, I went to the University of Pennsylvania, studied engineering. At a mechanical engineering degree, and from there I went to Rutgers and did the combined degree, both a biomedical engineering degree and also my medical degree. How
many years did that take you?
It took me 7 years. So
Okay.
what happens is you take the 4 years that would normally be for medical school, and you split them up the middle and add at least 3 additional years. And I say at least because it doesn't have to be only 3 for your graduate work, for example, for PhD. And at the time, it was called Robert Wood Johnson Medical School, but it reverted back to its old name, which is Rutgers Medical School. And after that, you're not done. Then I did residency at Temple University Hospital in Philadelphia. That's
In
residency.
neurosurgery.
Become a neurosurgeon. That's correct.
How many years is the neurosurgery residency?
Most are about 7 years long.
And that includes a first-year surgical internship.
That's how it used to be, that there was a separate internship. Now most programs have it integrated, and there's been some adjustments over the years. And if you want to be a specialist, like I am, then you need additional years of training. And there are different specialties within neurosurgery. You can be a pediatric neurosurgeon. You can be a trauma neurosurgeon. You can be an endovascular neurosurgeon, a brain tumor or cranial oncology neurosurgeon, a spine neurosurgeon. There's really a list that you can focus on. I decided to focus on spine specialty, and I did my training down here through the University of Miami and Jackson Memorial Hospital. And after I was trained here,
That's your fellowship, then.
That was my fellowship.
So your residency was at Temple in neurosurgery.
Correct.
And then in your 7-year MD, PhD program, some of the people listening might be pre-med or medical students. Did you do, or have relatives or whatever who are doing this training, did you do your clerkships, the clinical part of the medical school at the end?
What happens is they're mostly at the end. So the traditional format for medical school, and it's different at other medical schools, and for all I know, it might even have changed since I was in medical school, is the first 2 years are almost like high school, in that you're in class with the same people every day, taking the same courses, and you even have lockers, and it's usually a small group. Some med schools are as small as 100 people. Some med schools are as big as 200 people.
And we're going to talk about how incredibly hard it is to get in. The odds are against people getting into medical school.
It's true. It's very difficult. And so your first 2 years, you have to learn the science of medicine. You have to learn physiology. You have to learn anatomy, because you're not going to be a surgeon. You're not going to be an internist if you don't know the anatomy of the body. So you need time to learn that. You need to learn about
pathology.
Because
my dad's a pathologist, which is a laboratory physician, but sometimes they have the pathologist actually teaching pathology, which is preclinical. So they're the only MDs sometimes who are teaching the students really in the first 2 years.
I wouldn't say that. For example, you might have an internist or a renal specialist, a nephrologist, come give the lecture about kidney function. So when you're learning all about how the kidney works, you may actually have not a physiologist, but you may actually have a kidney doctor give that lecture, or there may be more than one lecture, and you get a mix that way. So,
but your pathology classes were taught by pathologists?
It's usually a mix. Sometimes you actually have anatomists and who are teaching some of your anatomy class, but I would say most of the time pathology was taught by the pathologists. And there are people who are pathology residents and pathology specialists, and it's actually a very integral part of your medical training. And really, every specialty uses their pathology knowledge. I don't think there's a single one that doesn't.
Well, my dad and my grandfather were pathologists, and my friend Denise,
who
hopefully we'll get at a show, is also a pathologist. So the first 2 years, basic sciences.
Yes, this is the traditional model. It's not always that way. Some med schools have gone a different route to try to get what we say in the wards earlier. And what we mean by that is there's book learning for medicine, and then there's learning with interacting with people. So in the wards would be when you have the medical student actually in the hospital or in a clinic learning from a physician, kind of like an apprentice, how to interact with the patient, how to do a physical exam, etc.
But they have to pass those boards, the first set of boards, after 2 years.
That's true. And so your USMLE boards part 1 is after your first 2 years. It's like a final exam for your first 2 years.
And my dad had the best-selling pathology board review book, I'd have to say.
Which one?
Well, BLRS, Schneider, and Satzel.
Oh, there you go.
SZANTL.
How about that? I might have actually used that.
Well, awesome. Medical students were always telling me they use my dad's book.
It's very possible.
Yeah.
And so in that traditional model, and again, some med schools do it differently. The first 2 years are mostly your basic sciences. So you're learning the language of medicine. But at the same time, you're still getting classes and coursework where you're learning how to examine a patient, where you have to learn how to do the physical exam. And most people know about getting their reflexes and getting someone to look into their eyes and the tuning fork into to have them hear. This is all something that gets learned and taught. And so that happens early on before you hit your 3rd and 4th year. So the traditional 3rd and 4th year is when now you are shadowing, meaning you're following around either physicians, who are completed their training, which we call attending physicians or residents, and you're watching and learning how you interact with patients. And
Now, how challenging is it at that point? Are you just observing, or are there anything that your assignments you're being given in the hospital?
It's usually a mixture. I can tell you in our more modern, legalistic, protected age, the amount that a medical student can do on his own or her own tends to be very limited. I remember where I was trained, it was very difficult to do certain procedures on patients, something like starting an IV line or even doing a lumbar puncture. Some people call that a spinal tap. Frequently, they didn't want the medical students to do it because of legal issues.
You're not licensed yet.
You're not licensed yet, but you can touch a patient, but only under supervision. And of course, you're the least experienced person there.
Can you hold the forceps?
Yes, you can hold the forceps, and lots of times medical students are the ones in the operating room doing what we call retraction. And they may be pulling the retraction device and looking at the surgery and doing some of what we call the grunt work. But at the same time, they are learning and observing. But you'll never have a med student being told, okay, you close up and finish the surgery. That does not happen.
Now, the hours are not as extreme as during the first years of residency, though.
Well, the hours issue kind of changed. I mean, if you want to read about the bad old days, there was a book called The House of God. And in this book, they talk about these just horrible experiences of early interns and how they spent almost every waking moment in torturous hours. And I actually was in the guinea pig years for the new 80-hour work week that was enforced on residency programs.
That's the residency, but did the medical students themselves also have those hours?
I don't think so, but their hours are usually not as bad as residents for a very good reason that med students aren't as useful because they really can do a much more limited task. For example, a medical student can look up lab values, but as an attending physician or a resident, you still have to double check this because ultimately you're responsible for this. And med students are so new that they can give you the wrong information, not because they're not trying, but they're very new at it.
So you think it's a little bit exploitative, the hours of residency?
Oh, I don't think so. I think there's a real balance. It's like I have to think of it as an apprenticeship. That you may be doing some of the grunt work, you may be doing some of the more arduous tasks, but at the same time, there's someone who's intimately responsible to making sure that you've learned the task, that you will be graduated, and you'll carry the imprimatur of whatever program to say you are a competent physician. So it can't just be, oh, I'm going to make you gather numbers for me and close all my wounds, but my surgical incisions, but I'll never actually teach you. Well, that program would very rapidly disappear. So
now, in those last 2 years, are the students still being tested, or are they just waiting for the second set of boards?
Oh no, they're always being tested. So I'm thinking back to my years as a medical student, but during those final 2 years, you're still taking quizzes. Basically, you're still
these are written quizzes.
These are written quizzes, usually internally to the school, and then you still have to take the next round of boards. Which is then
the second of three.
The second of three, and then there's a third round.
Which is after the first year of your residency.
That's correct. And although sometimes these things may change, and now a lot of it is being done on computer, where it used to be almost a rite of passage where the whole medical school would come together for the 2 days of the boards. And, I'm in the last classes that actually did that. I'm a bit of a fossil now, where there really was something almost like a major holiday where everything stopped, where for 2 days you were just taking exams and you had a big party all together afterwards because you just finished. Now it's just the exams coming. Oh, when are you taking it? Oh, I got a spot to take it at such and such a place.
Now, it's interesting from what I've heard from friends who are medical students, the few students, usually they're working so hard, but the few who don't pass the first set of boards, they're not completely screwed.
No, you can always take them again. But it's true that your scores will follow you, and when it comes time to apply for residency programs, for example, they do see what your scores were, and some residency programs are much more difficult to get into than others, and some fields are more difficult to get into than others. And so ideally, you don't mess up your boards, but if it happens, it's not the end of the world.
And internal medicine is a gateway for a number of fellowships like cardiology or other things.
That's true. I'm not an internal medicine physician, but I have many friends and colleagues who are. But you can think of the fields of all medicine sort of split into two groups. There's the medical fields and the surgical fields. And it's true there's overlap. There are some groups which kind of straddle it a bit. But basically, if you're more interested in treating a patient with an invasive technique, like you're going to, the joke phrase is heal with steel, because you want to do a surgery. Someone has a broken bone and you want to be, you're interested in doing the surgery to fix it, then you may have a great interest in orthopedics. If you're very interested in transplant surgery, well, you're definitely going to want to be a surgeon. But if you're more interested in, for example, thinking about taking care of someone from cradle to grave, and you want to help manage their diabetes, and you want to help manage their high blood pressure and keep them healthy and help them make smart choices, maybe you want to be a family practice doctor or an internist. And so you won't be doing things that are surgical. And it's true. So if you have a background in internal medicine, and then you decide you're actually very interested in the kidney, you might then take a fellowship and become a renal physician.
Nephrologist,
or a nephrologist,
right? Okay.
correct. And or you might
Or
find
endocrinologist.
or an endocrinologist.
If you're interested in hormones. I'm kind
That's
of
correct.
interested in hormones sometimes.
Absolutely. And you might even find yourself
I was
very
a little joking
interested.
about that, but
Indeed. And you might even find yourself interested in something else. I knew a family practice doctor who in his practice ended up being very interested in psychiatry. He didn't actually do a special fellowship, but as a family practice physician, you can treat everything basically. And his practice tended to have a little more of a psychiatric bent to it. There are other family doctors who are more interested in children, and they'll have.
well, there's actually a
children in
controversy,
there.
I understand. On the medicine side,
Mhm.
an internist or pediatrician can give antidepressants. They
Mhm.
can give statins, which are for cardiac conditions. They can give anti-epileptics, I think.
Mhm.
So it's like you usually go to a specialist, but you could be treated
Well,
by your general practitioner.
it's a little bit outside my expertise, so forgive
Well,
me if I
follow
make
up.
a
I don't
mistake.
feel
But what I will say is there's always the judgment of the practicing physician. If you are an internist who feels very comfortable with diabetes management, you may only refer to an endocrinologist for the patients who you find that don't behave the way you expect and maybe are a little challenging and you want another opinion. One thing that I do take some pity on my colleagues who are in primary care who have to deal with insurance companies, where you may be pressured to see 50, 60 patients in a day, and you don't get as much time to spend with each patient, and you have to get them through. So once you realize, okay, this is a problem that a specialist can handle, you end up sending them to a specialist. And that is certainly not a description of every primary physician out there. And but I
sometimes
know
they feel like they can take care of it, but they don't really have the time.
that's often true. And I really do feel for my colleagues. Maybe feel for is better than pity, but I should say I feel for my colleagues who are under that kind of pressure, who really maybe want to spend more time with the patient, but are pressured by the constraints of how many people to see in a day and the level of reimbursements. They have to see more and more.
I've actually known of friends who they work for clinics that are owned by hospitals, and sometimes they feel just outright overworked.
Sure, and that's a problem.
Too many
these days.
patients.
This is a problem that we're running into, especially in the healthcare market, where whenever there's a new rule or a new law or a new restriction and you get external management on someone's practice, you can run into problems. You know, the whole move towards the electronic medical record all by itself is a good thing. Electronic medical records are more efficient. You can more easily share data when appropriate. You can access data without having huge storerooms of patients' files, and all these things are very appropriate. But then we ended up with government mandates as to exactly what it must have and what it can't have, and then you end up getting rules, and some rules sometimes are a little silly.
So do you think that a lot of the government regulations are bad?
I think that might be overarching. I think central management is bad. And
Like big hospitals employing more of the doctors directly?
no, I wouldn't say that that's
The
bad.
Medicare Authority?
Even that I wouldn't say is bad. What I'm saying is whenever you have someone trying to micromanage too much stuff, you just can't be as responsive as you might need. For example, almost everybody we know now has a smartphone. There was never a rule and there was never a law passed requiring people to have a smartphone. People bought them because they liked the technology. The prices came down because people liked it. There are various different choices of different companies that people like one more than the other, and the market sort of went by itself. I fully believe that electronic medical records would have evolved on their own, and they already were evolving on their own, and different practices would acquire them and pick the right ones for themselves.
But to be fair, doctors have been surprisingly resistant to technology in some cases, that maybe because of the rigors of the science and their medical school education, I'm not always sure that, I mean,
I don't know if that's necessarily true. And I think there's always a little bit of, depends on the age of the physician and what you mean exactly by technology. I don't think there's a physician alive who doesn't like an MRI when appropriate.
No, I meant like as far as IT, information technology, like Microsoft Office.
Oh, I don't know. That hasn't been my experience.
Okay, so that's fair enough. We will touch, I think, if you want, on a little bit on your opinions on the Affordable Care Act. But you talked about the distinction between surgery and just general medicine.
Sure.
And two thoughts that come to mind is, first of all, it's interesting, like fields like interventionary radiology, cardiology, and is there interventionary neurology?
Oh, definitely.
And it blurs the distinction, the traditional
This is
distinction
true.
between the surgeons and the...
It blurs it to the point that, in fact, you get a true overlap. Like, for example, you can have cardiothoracic surgeons who can do endovascular cardiology and place stents in someone's heart vessels or coronary arteries. You also have cardiologists who do this. You have neurosurgeons and vascular surgeons who can operate on someone's blood vessels in the neck called the carotid to try to take out clots at the same time, or plaque, I should say. And these same physicians could also place a stent in there. But at the same time, an interventional cardiologist can also place a stent in there in some cases.
In the carotid artery.
In the carotid artery. And I know that they've been very anxious to do so. Whether or not they're actually doing that now, I'm not sure. But certainly there are interventional neurologists, and we have some in our own department, who actually will place coils and stents into the cranial vessels. And at the same time, we also...
the neurologists are doing that.
There are neurologists who do it, and there are neurosurgeons who do it. So in a way, it's almost the same blur that happens with spine surgeons, and that you have a spine surgeon who's neurosurgically trained and a spine surgeon who's orthopedically trained. And in Europe, you have some spine surgeons who are trauma trained. And let's face it, at some point, you can train almost anybody to do anything, but in fairness, you have to have a desire to do that. And I know for proceduralists, if I can make up a term there, for people who like doing procedures, and if we say surgery is a type of procedure, you have to have that kind of 3D vision and hand-eye coordination to do it.
Are neurologists at a disadvantage because they're not, for much of their training, actually doing actual mini procedures, and they're not basically cutting into the head?
That I can't comment on what neurologists do during their training. I don't know because I didn't do neurology training.
You should have become a politician, I think.
I don't know. I think I have a face for radio. I'm not sure I'm electable.
No, but, so anyway, this is unrehearsed, so sure. Obviously.
I don't know if I would say that they have a disadvantage because of that. I mean, when it comes to doing something like an interventional procedure, you also have to, I'll give you an example that's a little closer to me. Spine surgeons do things like putting large needles into someone's spine, into the bones, sometimes to take a biopsy, sometimes to inject something like bone cement in order to, say, strengthen.
That created a problem.
Right. That the bone cement, which can, for example, strengthen someone's bone. And that's if you have an osteoporotic fracture, that could actually be a great source of pain relief. At the same time, there are pain physicians who are not trained as surgeons who do interventional procedures, some of whom inject cement. And then the question is, well, what happens if you're injecting cement and there's a problem, like the cement leaks into the canal, the spinal canal?
Well, that became a criminal case because they were using it off-label.
And
the company marketed it in violation of FDA laws.
I'm not sure which company. So
Indiana company. It was owned, I forget who it was owned by.
I'm going to have to reserve comment. I don't know the case. But
it wasn't the doctors. It was the people marketing it.
There's a different problem that you're mentioning there with off-label usage of things, because the FDA sometimes approves certain things only for certain uses. But then you run into the issue that the FDA can be sometimes a little slow to catch up. And sometimes we do use things that are off-label but not inappropriate.
Well, it's judgment of the doctor. It's the legal judgment. But in this case, the reason that people ran afoul of law, doctors have the right to use their judgment, but companies cannot market off-label.
That's true. That's true. And you have to be very careful with that. And sometimes there's a fine line, because the doctors have to know what the technology is out there. And there really is a balance. And we have laws about this in Florida, the Sunshine Act and things like that, that we don't want physicians to be unfairly or inappropriately influenced by a company. But at the same time, a company has to let physicians know what's out there and what's
And
available.
how to use it.
And how to use it. So you run into a sort of balance. Well, what if a company has a new device, let's say a new type of screw, which they think is the world's best type of screw to go into the bones of the spine. And they would but it doesn't work the same way as every other screw put in, and they need to train the doctors on how to use it. Is flying a physician to a hotel in Atlanta, putting him up in the hotel, saying, okay, we're going to have a training course. We're going to train you how to use it. We're going to feed you dinner, and then you're going to go home. Is that considered unfair influence because he went for a training course? Now, it used to be in previous generations, they would fly the doctors to Miami and Hawaii and places, and you would train in the morning, but in the afternoon, then you would go and enjoy things. But you would still get the training.
Disney World when I was a
or
kid
you go to
times.
Disney World, etc. So there does become a bit of a problem line there.
But on the other side, I mean, people have to realize if you don't hire surgeons, they need the surgeons to develop the tools in the first place.
Often it's actually biomedical engineers who are developing it, and I can tell you.
But the surgeons have to be involved in the
You
development.
need at some point a clinical person, a surgeon, to work with an engineer. And here actually is something where I have some experience being both a PhD in biomedical engineering and an MD, board-certified spine neurosurgeon. I can put a foot in both worlds, and I can tell you that sometimes the engineers come up with an idea which solves the problems that were presented to them, but they really needed a clinical person to really lay out what are the problems that are really there and what will a clinician actually do. This actually happened. I was part of a thesis panel. Now, a thesis panel is when a student who's been training for his or her PhD now wants to present to a group of other PhDs who will now judge, is this research new, is it valuable, and is this person worthy of being assigned a PhD? Will now listen to that final presentation. And you usually have an outside member of the panel. In one case, that was I. And the student presented a very interesting new polymer approach in order to prevent certain scar in the spinal cord. And it was very interesting work. And he was describing a possible use where you could open up the dura, which is the tough bag that surrounds the spinal cord, and place this into this area. And I had to tell him afterwards, no surgeon is going to want to open the dura unless he or she has to. And that's not knowledge that they have.
So shouldn't surgeons be involved in the development
Frequently,
process?
absolutely.
And they have to be paid for it. That's only fair.
And they should be. But you have to then document what you were doing and was the payment fair. There have been cases of physicians who were, and I'm doing air quotes, which is no use to anyone on radio, but I'm doing air quotes, everyone listening, for someone who was a paid consultant. There they go.
They're the air quotes.
The air quotes. And really wasn't consulted for anything, but was getting a large amount of money from a company who I won't name. And they were using that, or that physician, I should say, was using that product almost exclusively. Well, that's kickbacks, and that's totally illegal. But there's
a lot of restrictions to prevent kickbacks in medicine.
Absolutely, and it's appropriate.
Like doctors can't always own the clinic.
That's true.
But they could self-refer.
Or, for example, if I were to own an MRI facility, that becomes problematic because what if someone could argue, well, Dr. Levene, maybe you ordered this MRI on Mrs. Jones, I'm just making up that name, because you wanted the money for Mrs. Jones to get this MRI, and you didn't really think that she would need it. So I don't own any facilities like that.
It's interesting. I always make an analogy. This is outside of medicine, but, lobbyists, state, federal, always get a bad name.
Right.
And yet, if we eliminated all the lobbyists, they're the representatives of the companies who know how industries work. Like hospital lobbyists, they know how hospitals work. If there were no lobbyists, Congress and state legislatures would be completely in the dark. And the same with the biomedical technology
maybe
companies.
We should have the same sunshine laws and the same anti-kickbacks between lobbyists and members of Congress.
It's a balance,
in the House.
I think, at the end of the day.
Right.
There's a theory actually in political science called embedded autonomy, which is you want people to be linked enough, government linked to private sector, that they're able to do it, but autonomous enough that's not totally corrupt.
Well, it's a tough balance to make.
You can't completely eliminate corruption or the potential for it without throwing out the baby with the bathwater.
Right. Well, all human beings well, no human being is truly infallible, and any large group of people can always run into trouble.
No system's perfect.
No system is perfect.
They say perfect is the enemy of good.
Yes, yeah, we say that too.
I mean, that's the killer. You could be like, everything's good, but hey, they're influencing doctors too much a little bit. You try to eliminate it, and then suddenly none of the surgical instruments work because they can't pay the doctors to develop it.
I can tell you, in my very early years as an attending, where sometimes an equipment vendor would say, hey, I've got some products I want to show you. Now, time is valuable. If he wants to show me some products, maybe it'll take me 15, 20 minutes before I say, I'm not really interested in what you're offering, but I have to see it, so I have to invest time in it. And sometimes they would say, well, let's meet for dinner. So the question then becomes, if it's a $50 dinner at the local steakhouse, and so they just basically reimbursed me for my time and fed me and then showed me their product, is that an unfair influence? Or is it they bribed me, basically? You could look at it one way, it's just they reimbursed me for my time. It took time for them to show me the product versus they paid me off to use it. I could tell you personally, I never felt that I was particularly influenced. I just felt like, well, this is my time. Then when the rules changed that anything more than $9.99 would have to be reportable and this would be considered bad, I just said, okay, forget it. We're not going to do any of these dinners. And that amount of time kind of disappeared. And if they wanted to come meet me, okay, you've got to schedule some time in my office. And who knows, maybe I could have been doing something else at that time. And then
you
it's a balance.
You have less time then to research new technologies
That's
that might
true,
help
too.
your patients.
It's true. I
The
mean,
dinners actually helped you find out more and learn.
it became, I would argue that we've overdone it. And some of those dinners I thought would just be an efficient use of time. Maybe you could argue it the other way. And who's to call the limit? Maybe $25 or $50 should have been the limit, and the $300 dinner was excessive. Who knows? At
Yeah,
this
I
point,
totally
I'll
agree
follow
with
the
you,
law.
by the way, because in the mid-'90s, I remember I've gone to dinners and congressmen were
Right.
invited, and it was like a $40 limit per plate.
Right.
And they couldn't feed like the congressman salads and everyone
Right.
else steaks.
Oh, and now they have things where, and I'm good with this, that at certain conferences, for example, academic conferences, there might be a lecture session and you can attend. If your spouse wants to attend and your spouse is not in the same field as you, you must pay for your spouse or significant other or friend or whomever you're bringing. And I'm okay with that. That's fine. And as with anything, there can always be some massaging of the laws. There have been studies that show that if you give physicians all sorts of freebies, that you do influence them. And they've gotten rid of things like, hey, doctor, here's for a certain drug that lowers your serum porcelain levels. Here, we're going to give you a pre-made prescription pad, so it makes it easier for you to write. Okay, they got rid of a lot of that stuff, and no problem. But then they got rid of the rules so much that when you're a starving medical student, it used to be there were pads of paper and pens and things that you actually needed, and it saved you a lot if you could actually have a few of those extra goodies, and you weren't really influenced anyway. It's just this was paper.
Well, all industries face this. Wall Street has these issues, and that doesn't strike me as fair because I know that you have a lot of freebies at a graduate business school, graduate law school. That seems like unfair to the medical students.
Yeah, and you know what? Life's not fair, and it's a tough balance. I think right now we're on the edge of the balance that we're afraid of any undue influence. Maybe that's not a bad thing. On the other side of the balance, maybe it wasn't so terrible to if they gave a textbook to a med student, because that used to be what would happen. It's like, oh, we have some textbooks that we bought. Nowadays, of course, they'd be online access and things like that. But it was just a regular textbook. It wasn't like this is a book only about our company stuff. It could have been a review book about pathology. But it had a
Somebody has
little
to pay
label.
for textbooks, and
Somebody
they're expensive.
has to pay for it, and they are expensive. It
I mean, my
actually
dad
was
had a textbook, so I know.
That's right. So it's a balance. I don't think there's an exact answer, and things will go back and forth. But it does come down to the issue of we don't want physicians to be unduly influenced. You don't want someone to be in the pocket of one particular industry. Frankly, I wouldn't want that of anybody. I don't want my senators and my congressmen to be in the pockets of anybody
But
either.
people don't understand the other side, I think, other times. It just sounds corrupt, and then they end up, everything starts to sound corrupt.
Right. And it's almost like, well, if every company gets a chance to offer you something, then it balances it out in a way. But if right now the law is you don't take anything, I'm going to follow the law. I'm not taking anything.
Now, you're primarily a spinal surgeon. So what
That's
should
true.
people most worry about in their backs, or preventative, or what are bad signs? What would you tell most of the people?
Oh, wow. Well, that's a very big topic. And
Which is why I think I'm going to have you back.
Okay. And what I'm going to start first by just with what most people think of with spine surgeons is back pain, even though the spine really starts at the bottom of your skull and ends in your pelvis. So the spine really also includes your neck and your mid-back and your low back. But most people think of back pain as different than neck pain, and it's low back pain. And it's not just one thing that can cause back pain. You can have back pain that's, in a way, mechanical in nature. Maybe the disc, which is the structure in between each of the bones in the back, maybe that's worn out and the nerve roots get irritated. Maybe the nerve roots that are exiting from the inside of the spinal column are getting pinched on the way out. Maybe there's been a herniated disc. Maybe there's a bone spur. Or maybe it's none of those things. Maybe it's a strain or sprain from a muscle that was attached to the area of the spine. Maybe it's referred pain from somewhere else. You don't actually have anything wrong in your back, but you had pain somewhere else.
Like the kidney?
Could be from your kidney, for example, flank pain. Or maybe you have a nutritional deficit and you're having some cramping. Or maybe, and this happens to people too, it's societally acceptable to say your back hurts, not I'm stressed and depressed. If you called up your boss one day and said, boss, I can't come into work today, I need a mental health day, he's going to say, you better come into work. If you called your boss and say, I'm having a flare-up of my back pain, I cannot get out of bed, he'll say, or maybe he or she might say, okay, you have to take the day off, and if it still is bad, you have to see the company physician.
Now, pain is subjective, so sometimes people might legitimately have pain, and then the doctor isn't able to find anything to verify it.
It's difficult because a lot of what happens in your diagnoses is you're listening to the patient, you're examining the patient, and on a sort of a general scale, roughly 80% of your diagnosis comes from the patient's history. And then the rest comes in from things like tests that you take, like an MRI, a CAT scan, or an X-ray, and other studies as well, like an EMG, which is an electrical study of the nerve roots.
Oh, yeah, I know a guy who specializes. He did a fellowship in EMG.
Sure. And but it can be very difficult. And sometimes you can have more than one problem that overlap. To give almost a simplistic answer, if someone, and my dental friends can correct me on this, but if you have a rotten tooth, you have a cavity, and the dentist comes along and prods you with a poker, and you say, ow, and you say it hurts right here, and you touch it with your tongue and you point, there's usually not a lot of doubt as to where your pain came from. You have a cavity, there it is, it's easy to see, and then the dentist takes care of it. And when you say, I have back pain, sometimes it can be a bit of a challenge to really nail down exactly where that pain is coming from. And,
a toothache could be a heart attack, actually.
Jaw pain.
Yeah.
But wouldn't be reproduced by your dentist poking that area. But you could say my back hurts, and it may be a very difficult thing to figure out exactly what is that cause of the back pain. And it can be a challenge.
Don't people who are depressed feel more pain? It affects their perception of pain?
It definitely does. In a very real way, all pain is perceived by the brain, where the pain starts from the little nerve fibers, let's say at the tip of your toe before you step on the thumbtack. It has to pass all the way up your spinal cord, get to the part of the brain that reinterprets this electrical, basically a neurochemical electrical signal, and interpret it as pain. And
see, this conversation is causing my neck to hurt.
Oh, no.
So no, just a little bit. But the pain does have, it can manifest real.
That's true. And there's even very, very bizarre kinds of things like phantom pain, phantom limb pain, where you can have someone who has a tragic accident, let's say, who's lost an arm, who then can say, my arm hurts. Well, how could an arm that's not there hurt? And there's all sorts of research into this, but basically it's the brain interpreting what's left over of the signals as pain. And there's no easy answer to say this is what pain is. Different people experience pain differently. Athletes have enormous thresholds for pain, and there's some people whose thresholds for pain are very
That's
low.
because of endorphins and hormones as well.
I'm
Natural hormones, hopefully.
I'm not sure I can say exactly if it's just one factor. There's all sorts of training, both mental and physical, that goes into an athlete. And you can have someone, and I remember a case when I was doing a pediatric surgery rotation long ago, where there was a young woman who had some abdominal pain, but she was a girl, I should say, a teenager, who didn't look that bad, and she was a bit of a puzzlement. Her films suggested maybe she had an appendicitis, or maybe she had something wrong with the adnexa, which are the lady parts internally in the pelvis and in the abdomen region. And since she didn't act like your typical kid with appendicitis, they didn't think at first that maybe that was it. And we looked at all different areas that it could be, and it turned out it was appendicitis. But this young woman was a very serious athlete, and her pain thresholds were high. So maybe she didn't act like your typical child with appendicitis because she was already trained to deal with pain. Just a possibility.
That's interesting. But they're removing a lot less appendixes now than they used to.
I'll defer that to my girlfriend, who in fact is a trained pediatric surgeon, and she does many of those in the pediatric community.
Your girlfriend's welcome to come on. That'll be interesting, different perspective, totally different side, because you obviously neurosurgery and spinal surgery. What are the most common spinal surgeries you're doing right now?
Well, for me personally, I do a lot of degenerative spine. The bulk of my practice is over at the Veterans Hospital. But I can tell you every month sort of has a different flavor. There was one month where I was operating a lot on patients' spines in their neck, where I had a lot of patients with degenerative arthritis in their neck, and I was doing a lot of procedures, which I'll first give the shorthand and then I'll explain it in English, something called an ACDF, or Anterior Cervical Discectomy and Fusion, which is a type of surgery where we go through the front of the neck, access the discs in the bones, replace the discs with bone plugs, put a metal plate in, and treat herniated discs in the neck with that route. And then other months, I had patients with a lot more pain in their lumbar spine, with degenerative problems there, with bone-on-bone contact causing a lot of pain, which needed to be separated with a variety of different surgeries. And I had a flurry of cases of patients who needed bone biopsies and injections of bone cement. And you never know what's going to happen on any given month. It's one of the joys of being a surgeon is it's a little bit of a cure for monotony. You just don't know what's going to
always
come
something
to your door.
different.
It's always something different.
A very nice mix, or a different mix.
That's true.
And so the cervical spine is the neck.
That's correct.
And when you do procedures with the cervical spine, do you ever work with ENTs or not really?
Personally, I generally don't, but it does happen on a few occasions. For example, if someone has had neck surgery already and there's been an injury to one of the nerves that controls the vocal cords, you may need an ENT doctor to help with that. If someone's had prior neck surgery and you don't know if both vocal cords are working and you want to do another surgery, you may need the ENT doctors to check out the vocal cords before surgery. Or if you've had a patient who's had, let's say, terrible cancer and radiation to the neck and things are going to be all stuck together, before you do a neck surgery, you may want a partner who's an ENT doctor to do the surgery exposure with you. So I won't say that I've never worked with an ENT doctor that way, but it's not frequent for me.
So from what I understand with what you were saying is that sometimes if there's radiation therapy aimed at the neck, there's side effects that make the neck more vulnerable when you're doing surgery.
Or more difficult to operate on, because radiation, by its very nature, is damaging to cells. It's damaging to tissue. And you want it to be damaging, for example,
the
to
cancer
the tumor.
cells. Yeah.
Right. But it damages other things as well. So you can have damage to skin and you can have things get stuck together. And when that happens, it's not like the anatomy textbooks anymore, where now everything is sort of stuck and things aren't in the right place where they usually are. And you may want someone who's also experienced in operating in the neck to be there with you to help do the exposure.
Are you involved in a lot of treatment of cancer, or really that you don't encounter that so much in your area?
I'm not a cancer specialist.
Yeah.
I have some partners who are. I really don't focus on brain tumors. I have many partners at the University of Miami Department of Neurosurgery who are brain tumor specialists who focus on that more than I do. I do deal with some bone cancer to the spine.
That's what I was thinking, but I don't know how common it is.
Like I said earlier, it just varies per month. So I know I've taken a look at some of my recent patients, and I have some patients who are coming in to see me because their oncologist don't know what kind of tumor is in a particular bone and they need me to do a biopsy. Sometimes that's a needle biopsy. Sometimes that's an open biopsy where you need to actually make a small surgical incision and remove a piece of bone. Sometimes I have patients who they just don't know what it is and they want my opinion. Sometimes it's not actually cancer of the bone, but there may be a cancer of the nerve. Sometimes it's a tumor. Maybe I shouldn't even use the word cancer, something like a schwannoma, which may need to be
benign.
surgically resected. Well, it can be benign in terms of it's not going to spread all over your body, but it can be very painful for the patient, and the patient may need a surgical resection as well.
Now, bone biopsies sound painful.
Yes. Whenever you cut through someone's bone, it's going to be painful.
And you do a lot of that. You have to cut through a lot of bone.
It depends on the kind of biopsy. There are needle-type biopsies where you can basically take what looks like a darning needle, which, unless you have some knitters in the audience, it just is basically a very big needle. And you, with the help of guidance, either with X-ray machines, which we call fluoroscopic C-arms or similar machines, sometimes a CAT scan, you direct the needle into the bone, and then you use this needle, which has a hollow portion, to pull out a core or a plug of bone. You know, in a very real way, it's not
Bone's
different.
pretty strong.
It can be. On some patients, it can be very firm, and on other patients, it can feel
Are
like
you using
styrofoam.
saws at all in your surgical practice?
Sometimes. And so I use saws. Usually I'm shaping an implant before I put it in if I have a small type of oscillating saw. We do use hammer and chisel sometimes.
Now, the skull is a very strong bone, right?
Yes,
Thin but strong.
that's correct. Some parts thicker than others. And to get...
Some people's skulls thicker than others as
That's
well.
actually true, and you can insert your Washington, D.C. joke in there. But it's true. If someone has a head trauma and where they now have a blood clot or a collection of blood or fluid underneath their skull, which needs to be surgically evacuated, you have to make your way through the bone, and that really does require a drill. For a while, pretty much the drills were hand drills, which looked like your good old-fashioned wood drill with different bits and such like that. And now we have electrical or pneumatic drills, which we use. And I pretty much use those, but I've also used the hand drills.
I've read
in
of
practice.
cases where in trauma, they actually have to temporarily remove a part of a person's skull. Yeah.
Oh, frequently. I've
and
done
then they
that.
wear a helmet once they get out of the hospital to protect their head.
If they have left the hospital without the bone being put back in, that is true. And absolutely, we do issue those helmets to protect people.
And does the skull, once this part of the skull is returned, does it just grow back largely the way it was?
Frequently. So it depends how you've also processed the skull when you've taken it out. One way is to actually not put the skull too far away. An old style technique is to take the skull out and then at the same surgery sort of tuck it into the person's belly. So it stays basically covered with nutrition and it's warm and it stays
inside the belly.
Inside the person's, not deep into the abdomen. It's not by his intestines or anything like that, but just under the skin. And when you're ready for it, you take it out later. And or you can basically freeze dry it and preserve it and in a sterile fashion and put it back in. Excuse me. And when placing it back in, you can use small metal screws and plates to sort of reposition the skull back where we took it out. And for the most part, it fits right where we've left it. Now, sometimes you don't actually have the opportunity to put the skull fragment back. Let's imagine there's a terrible trauma where someone's in a horrible car accident and their skull is literally fractured into hundreds of pieces. And at the time of surgery, those had to be removed and they're just not salvageable. Or someone has a gunshot wound that just destroyed part of the skull. So the ways to replace that are now either you can do it by hand and basically use putty, medical putty, and to shape it in the operating room to make the right shaped piece of plastic to put in. We have now computer-aided manufacture, computer-aided design, or I should say computer-aided design, computer-aided manufacture, CAD-CAM, to pre-make meshes or bone substitute to put into people's skulls. And if you have...
What about regrow the skull? They're doing a lot of this even with oral surgery in terms of jaw, lost jaw from gum disease and stuff like that.
Now you're getting towards my dissertation, as a matter of fact. But
which is an accident. I didn't really get a chance to get into that.
Right. So one other thing you can do, if it's a big enough defect but not too big, you can actually reach to the other side of the skull, take what we call a split thickness graft, meaning take some of the bone and move it to the other side. And that's a living graft. What you're talking about is a little bit of tissue engineering or guided tissue regeneration.
That was what I was thinking. I couldn't think of the first.
Right. So it's been done where you can take a mesh or a scaffold, and the scaffold, let's say, can be made of a bioresorbable polymer. And you can then place into this scaffold bone cells and let them grow in a bioreactor, and then implant that later. Now, that actually takes a lot of time to do it, and most of the time people's own bone can grow through an implant if you shape it right, and that's more like guided tissue regeneration.
I'm going to have you back soon, I promise. I think we're running out last minute.
Wonderful.
But it's interesting. So this is kind of cutting edge to tissue-guided regeneration.
Guided tissue regeneration, tissue engineering.
Which a lot of people are going to encounter with their dentist, actually.
That's true. In fact, dentists were some of the first pioneers of these techniques.
Well, also the mouth heals better than a lot of other places.
It's one of the fastest healing parts of the body, and sometimes too good. The gingiva, the gums, actually heal so fast that sometimes you need to put a barrier to keep it out of the area you're trying to build up or heal.
Oh, of the jaw.
Of the jaw, for example.
Oh, it's very interesting. It's very interesting. You have extensive training and experience, and I'm impressed by the extensive breadth of your current duties, from brain trauma to spinal surgery.
To guided tissue regeneration.
To guided tissue. Are you doing guided tissue regeneration right now?
Not at this very moment, but I am partnered with the
engineering
school. Okay,
we're going to have you back. So
and
that
we'll
was a great show. Yeah. Thank you so much.
Thank you, Michael.
Santo, the Santo Zone, and Howard Levene, Dr. Howard Levene.
Thank you. Have a great one.
Thank you for tuning into The Gray Zone, where you enter.
If you could choose any school from which to earn your college degree and be on your way to a better